Yes, we will switch to just humans. And in fact, I don't know if you know this, in 1997, the very first brain imaging study in IBS was published. And that was the year that I started my PhD thesis on stress and IBS. But at the time, I had no idea about brain imaging and didn't think that now, many years later, there's been quite a lot of evidence answering the question how stress affects visceral pain and the role of the brain in this. So I want to start with this cartoon, not only because it was drawn by one of the PhD students from my group, and I'm very proud of her because this accompanies her very first paper, but really because I think it depicts the close connection between stress and pain. And this person who's experiencing GI distress is clearly very unhappy and distressed. And this is also captured by a newer definition of what pain actually is. This came out last year in the Journal of Pain as a suggestion to replace the current EASP definition of pain. And this new definition defines pain as a distressing experience associated with actual or potential tissue damage, with sensory, emotional, cognitive, and social components. And I like this slightly updated definition very much, not only for the purposes of this talk, because it has the stress word or distress word already in it, but also because it stresses the close connection between sensation or nociception with emotional, cognitive, and social components. So there's obviously a large conceptual overlap and the focus on the brain where all this happens. Both pain and stress are subjective. Both are unpleasant or distressing. Pain is not defined by evidence of tissue damage. Neither is stress in humans defined by the objective demands, but rather by the subjective nature of the stressor. And both are psychological states. And why is this important for GI conditions, or in fact for all chronic pain conditions? It is these complex interactions between pain, negative emotions, cognitions, behaviors, that is really at the basis, the fundamental basis of all biopsychosocial models of chronic pain. So that's very general. And what about visceral pain in the functional GI disorders? Is there anything special here for visceral pain? I believe there may be. If you compare somatic and visceral pain, we already know that there are distinct, partially distinct afferent pathways and, of course, peripheral mechanisms. But if you consider from a psychological perspective the differences between somatic and visceral pain, somatic is mostly exteroceptive, it's easy to locate, it's visible, you know where it happens. Very different for visceral pain, it's interoceptive, it happens within our bodies, it's quite diffuse, it's poorly localized, invisible, and in fact, unescapable. So is it more unpleasant and more fear-provoking, possibly more distressing? We have looked at this recently in healthy women using a rectal distension model that we compared to a somatic pain model, and both pain stimuli were matched for intensity. So any differences we see have nothing to do with objective stimulus intensity. And as you see here, we've asked the women how fear-inducing the pain stimuli were before and after a series of stimuli, and it was clearly much more frightening, both at baseline and after repeated stimulation. And the pain stimuli, irrespective of intensity, the visceral pain stimuli were much more unpleasant before and even more so after a series of painful distensions. Again, matched for intensity. In fact, if you look at this, these were painful somatic stimuli. They were not even found to be unpleasant anymore in comparison to the visceral stimulus. It was also interesting to note that here the fear of pain predicted independently the amount of pain and pleasantness. That could be relevant clinically because it is unpleasantness that really defines the experience of chronic pain, and fear is sensitive to stress and in fact overlaps with stress. What about the brain? Here in the first blob pictures. As we would expect, pain activates a number of brain regions, and some of them overlap. So these are independent of stimulus modality. But we were, of course, more interested in what was different, and so we contrasted the response during visceral compared to somatic pain. And as you see here in yellow, those were differences with greater activation to visceral stimuli. And the blue ones were those with reduced activation to visceral stimuli. And when you look at these different regions, you could cluster these into especially regions that are mediating emotional arousal as well as cognitive aspects, which were differentially activated by visceral compared to somatic pain. And we interpret this as evidence that visceral pain is more salient than somatic pain and call for continued research in visceral pain with clinically relevant pain models such as the distension model. So the central networks that are involved in the processing of visceral pain are quite well described and have been here nicely illustrated by Emran Meyer's review a couple of years ago. And what's interesting and most relevant in the context of stress or chronic stress is, of course, the emotional arousal network that is both in terms of function and structure altered in patients with chronic visceral pain. But there's also conceivably a relevance of regions that have been here associated as being part of the salience network. What is not depicted are more cognitive descending pain inhibitory pathways that, as I will show you, could also very well play a role in the question, what does stress do with the processing of acute and chronic pain? We all know that stress, as John Crine said, is a whole body syndrome, and are well aware of the brain-gut axis. But I will sort of make the cut here, because that's my task, and really just look at the brain and visceral pain. And as you see in these blobs here, it's not just stress that plays a role in how pain is processed within the brain. There's a number of partially overlapping and related constructs in psychology, but also constructs that are different or not overlapping. So we have stress here that's closely related to anxiety, but there's also attention, there's emotional, pain-related learning, there are expectations, appraisal processes, and depression. It's probably more. But what I want to focus on is three areas, so I've divided my talk into three sections. I will start with stress and anxiety. Then I will move on to some studies that I think pave the way for future directions, pain-related learning and stress, and then finish up with some studies on expectations and how stress may modulate their effect on pain. So starting in humans, these were the first studies that have really looked at how does the emotional context modify what happens in the brain when you do stimulation in the gut, and these were esophageal distensions. Now, it's not quite so simple, it's nicer and easier in animal models, to induce stress experimentally. The group from Kaziz Aziz, you may not call it stress, but they have induced negative emotions, negative emotional states. In this first study with fearful faces, I don't know if you can see this, the comparison was neutral faces, and in fact they had faces that were different levels, of different intensities of fear, and have applied non-painful distensions and found differences in the neural response depending on what picture the participants were seeing. This was followed up by a study that also included painful esophageal distensions and sad or emotionally valent music compared to neutral music, and essentially found a similar modulation, especially involving cingulate regions as well as the insula. What was also interesting, well, the brain imaging studies were converging. This study found no effect on the perception of pain, so pain ratings were similar, and the other studies did find an effect. So what I think is important to understand is that the bold signal, as it is here measured with functional brain imaging, does not necessarily correspond with visual analog scale ratings or other subjective measures of pain. We've done this a few years ago with a different stress model. You may be familiar with the public speaking stress, which we can't really do during brain imaging, but we adapted this at the time to come close to that. And again, in healthy subjects, this is now in the lower GI tract with rectal distension, found that the response of the brain to these stimuli were affected. So now we know that this seems to be an adaptive, completely normal modulation, that stress or negative emotion states change the way the brain responds to stimuli. Now, what about chronic stress? Much more relevant, of course, clinically. In healthy subjects, not so easy. We've done in the same study here with the speaking stress, just a questionnaire on chronic stress and correlated this with bold responses and found some significant correlations. I'm sorry, you probably can't see, but it doesn't matter, with different brain regions of the emotional arousal circuitry. But as it also been pointed out, correlation does not equal causation. So this is always a problem in many human studies to really get into this, especially for chronic stress. That's why I like those experimental state studies. What about patients? There's very few brain imaging studies that have really experimentally manipulated emotions or stress. I've put here the three that I know of or that I found, two of them in IBS, one in functional dyspepsia. And again, the approach to actually change emotional state is very different here. We did this again with a modified public speaking paradigm. Last year, Shin Fukuda's group published a study where they applied exogenous CRH intravenously, so activated a part of the HPA axis. And this study by the Löwen group did not manipulate emotions, but looked at correlations between state anxiety during and before and after scanning and differences in the neural processing of esophageal distensions in functional dyspepsia patients. And all of these studies showed differences between the patients and the healthy controls in the way that these stress or stress mediators modulated the bold response. So acute stress, the response in the brain is altered in patients with functional bowel disorders. For chronic stress, again, as I said, we're limited, but there are two studies out there that have looked at the effects of severe traumatic stress, and that is abuse history, which, as you know, it's much more common in patients with functional GI disorders. And this study is the only study that has also included healthy controls that also had abuse history. So to be able to tease apart effects of abuse and effects of chronic pain. And what they found is that the group of IBS patients that had IBS and trauma history was the worst, both with respect to pain intensity, with respect to altered neural responses to distensions, and deficient activation of pain inhibitory circuitry. So that was this study, and in functional dyspepsia, there's also one study out there showing that abuse history, as one model, if you wish, of severe chronic stress, affects the response to pain in patients. Now, severe chronic stress does not just change the way the brain function is altered in the context of pain. We know from the pain field that it changes the structure of the brain. And this has been shown both in IBS as well as in functional dyspepsia, showing that if you control for chronic stress or for trauma history, many of the structural group differences or alterations in the patients disappear. Let me just give you this example. This is a study in 82 IBS patients on structural differences, the volume of specific brain regions. And everything you see here colored is different between IBS and healthy subjects. When you control for early trauma inventory score, virtually all of these differences disappear except for group differences in the amygdala that remain significant. And the same picture arises in these other studies that I've plotted here, So that chronic stress or psychiatric comorbidity, if you control for this, alterations in chronic pain patients are diminished or disappear completely. So we have to take this into account. We want to understand brain processes involved in chronic pain at this interface between stress and pain. So that was the first part, and now I want to move into some related subjects and bring this together. Pain-related learning, to introduce this, there has been early evidence in these distension studies, brain imaging studies, not only that the distension-induced bold responses were different in IBS and controls. The authors also early on described that during pain anticipation, there were differences in bold responses. Here you see there's a cue, so there was a cue that was predictive of when the pain would come, and just in response to this cue, patients showed different activation. Why is that relevant in the context of pain? Well, they could also show that this effect during anticipation modulated how the brain would then respond to the upcoming distending stimulus. So anticipation shapes pain processing. So we need to look more into this, and similar findings have been reported by the Löwen group also for functional dyspepsia. So this gave some initial clues how pain anticipation, that is of course learned, because how can we anticipate something if we have not learned it? So this cue learning is recently taking off, and it's essentially based, of course, on associative learning. We see a cue that means nothing to us, right? Pavlov did the bell, and the bell is irrelevant until it is associated with a biologically relevant stimulus, and that was here, food. Well, to translate this to cues and pain, a number of interesting and really, I think, innovative paradigms are coming out to transfer this to pain-related conditioning using very different types of cues, some interoceptive, some exteroceptive. And I'm sorry, it's so far at the bottom. I've put the references that have come out over the last 2-3 years from different groups, establishing new conditioning paradigms in visceral pain. We have used neutral visual cues, and this is based on fear conditioning, classical fear conditioning. Some of these cues we pair with pain, with rectal distensions as US. Others we leave unpaired, so they become safety cues. They predict safety from pain. And we're trying to answer these questions here. Does this condition, fear, lead to pain amplification, or rather to hypervigilance, or change how sensitive our sensory tract is in differentiating different stimuli? And at the same time, it appears that these safety signals are quite relevant, also clinically relevant. They're not neutral after they've been trained to become a safety predictor. Let me show you some data. Again, coming back to the specificity of modality here. If we train participants to learn predictive cue properties for an upcoming visceral compared to an upcoming somatic painful stimulus, both cues are pain signals, very reliable. Well, only the visceral pain predictive cue becomes very unpleasant. Participants really do not like the stimulus. It predicts visceral pain. The stimulus that predicts somatic pain of equal intensity is irrelevant. So again, the visceral modality seems to be special here. And if we then look at the cue-related visceral activation, we learn that it predicts statistically what happens during painful stimulation and explains part of the difference in the neural response to visceral compared to somatic pain. This also holds true within the somatic modality. We have trained participants to cues predicting high versus low intensity visceral pain, and then present different cues and look at how they impact the neural response to pain. And we can show here all of these are differences just relating to which cue preceded the distension. What do we know about patients? Well, it is becoming quite clear that this predictive learning, these associative cue-related learning processes are altered in patients with IBS. Patients with IBS, they are more contingency aware, so they're more aware of the predictive cue properties. They show more valence responses and differential neural processing in the amygdala, as shown here, compared to healthy controls during learning. And beyond learning, as you know, learning is followed by extinction, and then the memory trace is not gone, it's not extinct, it can be reactivated, and we tried this here. Actually, this is the work of Adriane Eisenhower during her PhD, that when you do a memory retrieval test and you reactivate this in the hippocampus, IBS patients have, again, a stronger differential activation to the former pain predictive cue. Now, what does that have to do with stress? We're moving into that, but there's 2 studies coming from Emran Meyer's group from UCLA, adding a CRF antagonist during a similar type of emotional learning and extinction paradigm. And here the authors showed connectivity changes in patients and in controls in response to this antagonist, and again could show that the antagonist affected in patients emotional arousal circuitry. How much for time? So that was the part on learning and fear learning. And to finish off, I want to talk a little bit about expectations. These cues that I've mentioned, of course, elicit expectations, but there's also different types of expectations. For example, those that patients have when they expect to receive a very effective treatment for their pain. You're familiar with placebo analgesia effects, for example. But also, they could have negative expectations about pain or treatment that may fail, and that is what we refer to as nocebo effects. These are mostly cognitively driven, but they are probably sensitive to stress, and that's what I will finish with. But first I want to talk a little bit about the nocebo phenomenon in visceral pain. This is first to show you what this looks like on a subjective level. Here we have a VAS difference before and after a placebo and a nocebo intervention or manipulation. And you see placebo analgesia, so large pain reductions with positive expectations. And this was the first time that we could show a nocebo hyperalgesia in healthy subjects. So that's quite a large difference. So that's almost 50 millimeters on a VIS scale. So these effects are quite powerful. We've tracked this in the brain, but I want to skip this and want to show you this follow-up study where we specifically looked at treatment expectations. This is clinically highly relevant. There's a placebo treatment where we tell patients they get a spasmolytic drug and that reduces subjective pain ratings. And there's a nocebo group that is told that they receive an opioid antagonist, which will increase their pain, so they have negative expectations. And again, there's a large difference, only due to these expectancies. It has nothing to do with learning. This is what they're told in this treatment context. And then we can show that this changes how the insula responds to identical distending stimuli. So this is not just a response bias here, it actually changes how the brain responds to painful stimuli. There's no nocebo studies yet on IBS patients, I should note. But we did try to answer the question, well, if this nocebo phenomenon has to do with negative expectations, what does it have to do with stress or anxiety? Well, the first thing we did is we, of course, took questionnaires and looked at cortisol, but we couldn't see that this is mediated by anxiety. But maybe it's moderated by anxiety. Maybe anxiety or stress changes that and could make the difference bigger. That was our hypothesis. Sort of modeling the patient that comes into a treatment and is highly stressed. How do you study that? You can't with brain imaging, and I'll show you why, and this is how we studied it. We randomized 120 healthy volunteers to address that question. So I guess it's technically feasible to do it with brain imaging, but at least not in a single-center study. We gave distensions 2 times to be able to compute difference scores. And then we first randomized participants to undergo psychological stress, public speaking stress paradigm, or control conditions. And then we gave them the different placebo, control, or nocebo instructions about the treatment. So you can see in the end we had 6 different groups, and this came out a couple months ago. Just to convince you how powerful that public speaking stress paradigm is, it's actually combined with an arithmetic task, so I'm spared the arithmetic part. State anxiety, huge increases, cortisol, huge increases, heart rate and blood pressure. So these subjects in the stress group really received their treatment instructions, which were deceptive. They all received saline, that were really stressed. And what happened? I will just show you the data for urgency, rectal distension-induced urgency. The control group, well, there's some differences. This is the placebo group, this is the neutral group, and this is the nocebo, the negative group. We don't really have power to get this significant. But the stress group, you can see how much impact the treatment information has when the subjects were stressed. And you see that both the placebo effect, but also the difference between nocebo group and neutral group really enlarged. So we say that these stressors could amplify the effects of treatment expectancy. Whether this translates to clinical situations, we have to see, but this is a proof of concept study. And that was my last experimental study. So I want to sum up and have some key messages. Pain and stress are intricately intertwined. Stress affects the structure of the brain in patients with chronic pain. It also shapes the functional brain responses, not only during but also in anticipation of pain, and that has implications for learning and memory processes. And acute and chronic stress are not alone. There's other psychological traits and states, as I've tried to show you, that play a role here. And it's not just pain, but rather visceraception in general, and with its many facets, that is probably affected here. And I've tried to put this in this graph to show you how all these different psychological factors not only affect pain, we could already show urgency is highly modifiable, but there's data coming out that other visceral sensory sensations that are relevant for a number of clinical conditions in the field of GI are affected. And I hope more people will join the research efforts to tease this all apart. So in the end, I would like to, of course, thank the funding agencies that have made this work possible and the many people over the years that have contributed to this work. Thank you for your attention.